Morning everybody on ADN 402 and welcome to the webinar on fluid balance and shock. My name is Rachel Pascoe and I'm one of the lecturers within the School of Nursing and Midwifery, and Caroline has asked me to do a session for you on fluid balance and shock. I noticed from my attendee list that people are arriving as I speak, so I will get started. Caroline, your module lead, has kindly uploaded this presentation in a PowerPoint as well as a supplementary piece of information with some references. So you've got plenty of information to supplement this session, but also this session will be recorded and uploaded to the DLE later on today. As there are quite a lot of you in attendance today, I'm not going to open any mics. But if you at any point wish to ask a question, please type it in and submit it. And at points during the session, I will pause and address some of the questions that have come through. But I'm not going to stop and answer questions as they arrive. Okay, so this is your first adult nursing module. But you've all been here for a little while and you've all been out in practice, so hopefully you've all had some level of insight into some of the things that we're going to discuss today. Please don't hesitate to ask questions, and hopefully I'll address all of them as they go along. But as there are quite a few of you, hopefully I'll have time to address all questions if they come in. If I don't, of course, I'll try and come back to them at a later stage. Okay, so let's get started. This morning, as I said, we're going to be talking about shock and fluid balance. First of all, we're going to just have a little bit of a look at the fluid balance side of things. So hopefully all of you are aware of that there is a large quantity of fluid in everybody's body that allows us to transport things around ourselves for all sorts of different reasons. So one of their functions, as it says there, is just to transport oxygen, because we need to get oxygenated blood all over the body to ensure that our tissues stay alive. We need to take carbon dioxide away from our tissues. We need to transfer nutrients around our body. We need to move electrolytes. Equally, we produce hormones in certain places and they act on cells and organs around our body. And we also will have waste that's produced, and that is taken and stored and then excreted at certain times. And we also have to lose heat from our body sometimes if a particular part of our body overheats. There are, as I'm sure you are all now aware, there are a number of very complicated chemical reactions that are going on around the body. I'm just going to pause. A couple of questions have come in regarding the PowerPoint. The PowerPoint is already uploaded to your Moodle site, your X site, so your mega site, as is the supplementary material. That's been there for a week or so now. It's only the recording that will be uploaded later. So the PowerPoint is already there. Okay. So that is the purpose of body fluid as it transfers around the body. So it enables these chemical reactions to occur, and it enables all the tissues around the body to function properly. So I've just drawn a little bit of a picture there about how much fluid is in our bodies. So if we look at, one is meant to be a man and one is meant to be a woman, as you can see. So if we look at the male side, your average 70 kilogram male, 60% of their body is made up of fluid, which equates to roughly 42 litres, whereas in females, it's about 50% of the body and therefore approximately 35 litres, and that's of your average or a 70 kilogram female. What you need to think about with that visualization is that obviously people's weight is very altered, and there are a number of other factors that we need to take into account. So roughly 60% of men and roughly 50% of women is fluid. Now, this amount of fluid will change according to a number of different factors. So as I've just said, depending on gender, so males carry more body fluid than women, and also it will have a weight will make a difference. Your body type might have an influence. So if you are very fit and your muscles are in a very good condition, you might carry less fluid. If you have a certain physical conditions, as I've said, health status there. So if you have certain conditions in the body, certain diseases cause you to retain fluid or have an influence on the amount of fluid that you have, and certain conditions, so certain conditions make you have more fluid and certain conditions have to make you have less fluid. So you need to think about the health status of your patient in front of you and try and work out what's going on. So if you've got an older person, their levels of body fluid, their tissue elasticity and so on has degraded over time. So the older you get, the less body fluid you have. So if we go back to the previous slide and we look at the average 70 kilogram male with 42 litres, as a gentleman gets older, that 42 litres may decrease. So the percentage of fluid will go down. Why do men have slightly more fluid than women? Because their vessels are slightly bigger. So and it makes very little difference to the reaction in the body, but men's vessels, so I'm talking about your arteries, your veins, your capillaries, your lymphatic system, they are by millimeters bigger than females. So with all of that network of tubes and vessels, if it's a millimeter bigger on everything, obviously that percentage is going to change, which is why men have slightly more fluid in them than women. As I've just said, as you get older, that fluid decreases, your body type, your level of fitness, and it alters dependent on whether you're male or female, and there are certain diseases which will have an influence on the amount of fluid. I'm not going to list all the different diseases that have an impact on the amount of fluid you have in your body, but you can imagine that if you have a kidney disease, that's going to have an influence. If you have some certain cardiac conditions, that might have an influence. So think about what disease, what is actually happening with the pathology of the body, and see whether that might have an influence on the amount of fluid. So generally over the course of the day, and these are rough estimations, that we take in approximately 1,500, ideally we take in approximately 1,500 millilitres of liquid in a day. We might take in about 700 millilitres of fluid in our food, and oxygenation and oxidation causes us to gain about 200 mils of fluid, which roughly equates to about 2.5 litres or 2.4 litres of fluid going into our body over the course of the day. With normal skin evaporation and normal skin perspiration, we are losing 350 mils of fluid and 100 mils of fluid respectively. Over the course of expiration, so that's breathing out, we lose another 350 mils approximately of fluid In feces, we lose about 200, and in urine, we lose about 1400 mils of urine a day. So over a 24-hour period, if we took in enough liquid and all our body functions were working normally and there was nothing additional wrong with us, then we should be in a perfect fluid balance. If any one of those amounts changes slightly, we can compensate for that. So if we drank a little bit more or drank a little bit less, or we perspired a little bit more or perspired a little bit less, we would be able to adapt. But what you need to think about in that equation is that if something dramatic happens, then there is going to be a dramatic shift in the amount of fluid we're either losing or gaining. So for example, if we drank a couple of litres of water, we might shift the balance a little bit. Now, if all your body is functioning normally, then you will pass more urine. Your kidneys will acknowledge that you've taken in all this extra water and they will excrete extra urine. So if we took in an extra litre of water, we'd probably excrete an extra litre of urine, and we'd maintain our fluid balance. It only becomes a problem, of course, if we can't do one or the other. So if we took in a lot of fluid and our kidneys weren't working, we would retain that fluid. Equally, if we didn't drink enough and we were suffering from diarrhea and we were losing more than 200 mils of liquid in our feces because there was an imbalance and something going on, then equally we could become dehydrated. Again, if you are previously fit and healthy, that's not going to be a problem because you'll compensate over a period of time, and you might be dehydrated one day, and you might be able to replenish those supplies the next day and get your body back into fluid balance. It's only when this becomes a critical problem do we need to act. So if you'd had prolonged diarrhea and you weren't able to take in fluids, we might need to intervene. Equally, if you'd been drinking masses of liquid and not being able to pass urine, we might need to intervene, either with drugs or some physical support. So it's very important to keep an eye on our fluid balance. Obviously, when you have a patient in hospital, if they're in an acute hospital, we might have a fluid balance chart to record. And it is always very important to keep an eye on our fluid balance charts and to see what's going in and what's going out to make sure that our patients are in fluid balance. So fluid balance is always about having the right amount of fluid in the right place at the right time, containing the right solutes. So we want to ensure that the liquid that is in our bodies is in the place it's needed at the time it's needed. So do we have enough liquid in enough body fluids to ensure that all our body functions are happening at the right time? If, of course, we have become unwell or we have sustained some sort of injury, this will lead to fluid imbalance. And any type of fluid imbalance can lead to shock. And I'm going to discuss now a number of different types and classifications of shock. I'm just going to pause at that moment and see if anybody's got any questions on the fluid balance part. Any questions on fluid balance? Okay, so some of the questions that have come in. Yes, you do want to keep it roughly equal input and output. And I say roughly equal. There will be times when you want a little bit more fluid. So for example, on a hot day, you are going to expect to lose a little bit more in perspiration and evaporation. So you might want to increase your fluid intake. But yes, you want it to be roughly equal. It doesn't need to be exactly equal, because if your kidneys and your heart and every other part of your body is working and is fit and healthy and you have no issues, then there isn't a problem with there being a slight imbalance if you are healthy. But what you want to do is to keep it roughly in the right equal in and out. Solutes, do I mean electrolytes? Yes, I do, but additional to electrolytes, I'm also talking about other solutions like glucose and not just what I would refer to as your electrolytes, or electrolytes being your urea and creatinine and sodium and potassium. So I'm talking about more than just that. How long can the body be in balance before shock sets in? Well, I'm going to cover that in a minute, because there's going to be, it can be a second, and it can be an hour, it can be a couple of hours. If you are healthy, you should be able to self-monitor. So if you feel thirsty, you drink. If you need to go for a wee, you go for a wee. You should be able to monitor these things. You don't need to record it. It would only be if you were suffering from a cardiac problem or suffering from a renal problem. You might think you might need to be keep a closer eye on what you were taking in and what you were losing. And I'm sure, well, I'm not sure, but I'm hoping that some of you will have looked after patients who've either got cardiac problems or renal problems or liver problems or respiratory problems, where keeping an eye on your patient's fluid balance has been a priority. Certainly if you've worked in an acute medical or acute surgical environment, it will have been discussed, especially in surgery, because of course they've been to surgery, they may have lost additional amounts, they might have intravenous fluids going in, so you'll need to keep an eye on them. But in a normal, healthy person, I'm not expecting you all to start charting what you drink and how much you wee, but you should be able to know that if you're in balance. But equally, your body should tell you if there is an imbalance. I don't know if any of you suffer from headaches if you don't drink enough, or become quite tired if you haven't had enough fluid intake. All of these can be your body's way of letting you know that you haven't hydrated enough. You might feel a bit lightheaded if you haven't eaten enough. That means that your blood sugar might have gone down. Those of you who've done some night shifts already might have noticed that you have a dip in your blood sugar at around 3-4 o'clock in the morning. That's your body letting you know that it needs some help. You need to go and have a cup of hot sweet tea or a biscuit or something to just get your electrolytes and your solutes back in balance, so that you've got enough energy to carry on. So all of these things are your body's way of telling you that you need to stay hydrated and you need to eat a little bit more. Equally, if you've become constipated, you might feel uncomfortable. If you haven't been able to go to the loo for a while, you might feel uncomfortable. So again, these are your body's way of telling you that you need to either put more in or let more out. I'm just looking at the questions. Have I covered everything? If somebody lost a dramatic amount of weight, so they weren't 70 kilograms, their percentage of fluid would remain the same, but they would have less fluid in them. So whereas it said that they had approximately, if they were a female, 35 litres, that would go down. The percentage wouldn't change, but you need to keep that into consideration if a patient's had a dramatic loss in weight or equally they've lost weight over time, their amount of leeway in terms of how much they can afford to lose will be reduced. So whereas a 100-kilogram person who would have many more litres of fluid than somebody who weighed 50 kilograms, and therefore if they lost a litre, it would be a far more dramatic effect. Hopefully I've answered all of your questions on fluids. Okay. Any more questions before I carry on? Okay, so now I'm going to talk about shock. So as I've said, we've got a balance in our body that's occurring in all of our organs, all of our key vital organs are ensuring that we're staying in fluid balance. And then if we go into fluid imbalance, that leads to shock. You've probably heard the expression in shock before. What I'm talking about is physiological shock now. I'm not talking about somebody jumping up behind you and going boo. That's not what I'm referring to. I'm talking about physiological shock. Okay, I'm just going to address this question as it's come in. Maintaining accurate fluid balance. If you look at the research, and there has been an enormous amount of research done on maintaining accurate fluid balance, it's not something that we nurses do particularly well sometimes. You must never assume that the patient hasn't drunk anything. You must ask the patient, so you must question them and ensure that your fluid balance chart is kept accurate. So you must never assume that they haven't drunk anything. You need to ask them. A healthy adult needs to drink 2 to 3 litres per day. To maintain the physiology in the body, you only need to drink about 1,500. Some people need more, some people need less. If you are undertaking any kind of physical activity, then you need more. If you're expecting to get hot, i.e. perspire a lot, you need more. If you are used to drinking 2 litres of water a day, then that's what's going to maintain your health. But to maintain pure fluid balance, you need 1,400 mils roughly of water a day. Yeah, we're not particularly, as I said, we're not particularly good at maintaining fluid balance charts, and maybe when you next go into shift, you can have a look at the fluid balance charts and see what's going on and why people aren't filling them in and whether they've been accurately completed. Yeah, it might be a good idea to encourage patients to record their own fluid balance, but where accurate fluid balance is really important, the patients tend to be incapacitated in some way, so they might not be able to record their own fluid balance. But it doesn't mean that you can't ask them if they've had a drink, what they've drunk, and roughly how much that is. So hopefully we can find a way to improve it, but it is, if you look at the research, something that's not done particularly well. Okay, so talking about shock now. Shock affects all parts of the body. It can happen very quickly or it can happen very slowly, dependent on the cause, and we're going to look at some of the different types of shock. What we're talking about when we talk about physiological shock is the loss of circulating volume. And that causes poor tissue perfusion. So if you remember what I said earlier about fluid needing to be circulating around the body to ensure that tissues were well perfused and working properly, so that we were all organs in the body were functioning normally, then if we get a loss of that circulating volume, then it causes poor tissue perfusion. Do I think, sorry, just to address this question, do I think the fluid balance is ever? Not always, and it rather depends on where you work. If at some point you have the opportunity to go into intensive care, they do take the insensible losses into account, such as perspiration and so on. But on your standard fluid balance chart on a ward, no, they probably don't. But I think that the insensible losses are equal on both sides, expiration, perspiration, and so on. So it's still looking at a broad fluid balance. Okay, so shock is the loss of that circulating volume, and now we need to look at what type of the stages of shock. You may have already heard the expression of fight and flight response. That's what we call compensatory shock. That is when the body is doing everything it needs to act and react to the assault on the body. So if something has happened, the heart rate might increase, the amount of adrenaline released might increase, and so on, which gives you the ability to fight off what's happening and possibly run away if that's what the body needs to do. Then we call that compensatory shock. This is where the body is doing all it needs to do to maintain balance. The next stage of shock is progressive shock, and this is when we are going to see symptomatic presentation. And what I mean by that is, at this stage, progressive shock, things are going to start going wrong. This is when the blood pressure isn't going to be appropriately controlled. The pulse rate is going up dramatically outside normal ranges. The respiratory rate is changing, and so on. There are going to be signs and symptoms that the body is no longer managing the assault on the body, whatever that assault is. Our observation charts, our assessment tools, when we're managing our patients, are geared up to looking for the signs of progressive shock, and try and adjust to and react to what is going on, to try and either prevent it becoming worse and alleviate the symptoms. And then we move into irreversible shock. And when we move into irreversible shock, that's exactly what it says on the tin. At that point, permanent damage has occurred, which could lead to death. So if we don't manage the patient in progressive shock, they will fall into irreversible shock. And irreversible shock is where, as I said, permanent damage occurs. Just going to look at this question that's just come in. When blood has been lost. Okay, I'm going to cover that when I talk about hypovolemic shock. Okay, so we'll talk about that in a minute. If you've still got a question after we've talked about it, then please ask it again. Okay, so the stages of shock, as I've said, fight and flight response, then we go into progressive shock, then we go into irreversible shock. And those are the stages of shock. Now I want to talk about the classifications of shock. So we have different types of physiological shock. And these fall into three broad categories. First, talk about hypovolemic shock. We're then going to talk about cardiogenic shock. And then we're going to talk about distributive or vasogenic shock. So these are different types of shock, and they include different things going on. So, as I said at the beginning, shock affects all parts of the body. So when we're talking about these different classifications, we're talking about the different things that are going on. So, first one we're going to talk about is hypovolemic shock. And hypovolemic shock is sort of exactly what it says on the tin. In hypovolemic shock, we have dramatically lost volume. So approximately 15, we'll cover that in a minute, anaphylactic shock. Okay, so hypovolemic shock is the dramatic loss of volume, and that is the key part. We have lost this volume. 15% or to 25% of the body's circulating volume has been lost, either through hemorrhage or some other means. But what we're talking about is loss. If we've got a decreased blood volume, so that circulating volume that we were talking about, that fluid that's circulating around the body, includes our blood volume. There are supplementary parts to our body fluid, but I'm mainly talking about blood volume here. So that's all the stuff that should be in the veins and arteries and capillaries and the organs in the body. So our blood volume. If we've got a drop in our blood volume, we're going to have a drop in the amount of venous return that we have. So the amount of blood that is coming back to the heart from around the body, which is going to mean that we're going to have a reduction in our stroke volume. And our stroke volume is the amount of blood that leaves the heart at systole. So at that point where the heart ejects the blood when the heart beats at systole, that is our stroke volume. So the amount of blood that leaves the heart. So we've got less coming in, so we've got less going out, which means that we've got a reduced cardiac output. So our heart is pumping less blood out into the pulmonary circulation, which is where we send the blood to the lungs to become oxygenated, and then it comes back into the heart again, and then it's ejected out into the aorta and around the body. So we've got less circulating, we've got less coming back to the heart, we've got less leaving the heart, and we've got less going round the body. And this means that we've got less blood perfusing our tissues. So what do you think firstly, what do you think might cause a hypovolemic shock? So I've mentioned hemorrhage there. So some of the other things that might have caused a loss in blood volume might be hematemesis. So when we vomited blood, it might be caused by a PR bleed or a melena. So that's where we've lost it through our feces. We've bled into our gut, and it might have come out one end or the other. So that's hemorrhage, internal. We might lose it through an epistaxis. So an epistaxis is going to have to be a very dramatic nosebleed, but it can happen. We might have had an injury. So we might have sustained a car accident and caused an injury that way. We might have had a traumatic injury. We might have been stabbed. Equally, we might have undergone some surgery. So we might have been opened up and lost our blood volume that way. So we have lost a proportion of the amount of blood that's in our system. So what is going to happen to our blood pressure? We've got less circulating volume and we've got less cardiac output. So our blood pressure will drop, absolutely right. So our diastolic and our systolic blood pressure will drop pretty equally. So our top measurement and our bottom measurement. So we've got a drop in our blood pressure. We're also going to have a raise in our pulse. So our pulse is going to go up and our blood pressure is going to go down. The blood pressure goes up because the heart is trying really hard to get blood around the body. and it's got less leaving, so it's going to have to beat quicker. And that can cause problems because we're going to be pumping and pumping and pumping. So we describe our patient as becoming tachycardic. So our patient has a high pulse and a drop in blood pressure. So our key indicators, the key things that we're going to be looking for in a patient who we think might be bleeding from somewhere, and that might be internal, so we might not be able to visually see it like we can with a stab wound or an epistaxis or a hematemesis. It might be going on inside. There might be something going on that we can't physically see from outside. So if we've got a patient who is becoming tachycardic, their pulse is going up, and we've got their blood pressure is going down equally, so systolic and diastolic decreasing at about the same rate, then we've got to ask ourselves questions about whether our patient is becoming hypovolemic. One question's come in about, can any of these things happen from giving blood? I'll talk about when we have too much volume at the end, but giving blood, it depends whether if giving blood has caused an allergic reaction or an anaphylactic shock, which we're going to discuss in a minute. But if we've simply got more blood, so can any of these things happen from giving blood? If we have taken off 1 litre, which is usually when we donate blood, we don't take that much off, and you have to be well to donate blood, and what happens is that you compensate for that very quickly. Okay, so hypervolemic shock isn't a thing. We don't talk about hypervolemic shock. If we're talking about somebody who has too much volume, that they're in retention, either that's a completely different physiological condition, and we're not talking about that today. We're talking about hypovolemic shock, physiological shock. Will a patient turn blue? As it says there, decreased tissue perfusion means that all the peripheries may have a reduction in their perfusion, which means that our peripheries, i.e. our hands and our toes, our fingers and our fingers might become cold, and they might become quite pale. If our patient is becoming blue, that's usually due to a lack of oxygenation, which can occur, but tends to have occurred quite far down the line. What happens to their O2? I presume what you mean by that is what happens to their oxygen saturation, i.e. what percentage of their blood is now oxygenated. That will reduce as well, because as our reduction of stroke volume occurs, there will be less blood going round the pulmonary system, there will be less oxygenated blood being circulated, and then our patient might will reduce their oxygen saturations. When I say a dramatic loss, 15 to 25% of the blood volume is what I'm talking about we're losing. Other fluid is supplementary, and I'm talking about just blood volume here. Will a patient go grey? Their visual appearance may appear, their pallor may change as there is a decrease, as I said, in tissue perfusion. They may become quite pale, and that might change their pallor. Whether you consider them to be grey or not will rather depend on their skin tone. as people's cardiac output decreases and their pulse rate increases, their respiratory rate tends to increase with it, because we're trying to oxygenate as much blood as we can. It depends how you define cyanosis. Cyanosis is a reduction in oxygenation, and at the moment we're simply talking about a reduction in tissue perfusion, which then will cause our oxygen saturations to drop. Cyanosis is caused by a dramatic drop in oxygenation, which hopefully we will be able to adjust and alleviate. I'm just looking at some of the questions. Yes, the patient may appear clammy. Again, as decreased tissue perfusion occurs, we can start to sweat, which is again when the body, because we've caused a knock-on effect and the body now becomes imbalanced. So a lot of the functions of the body are no longer working as they should. So we may sweat, we may become cold and clammy, and that's often a sign of hypovolemia and reduced tissue perfusion. How much blood we have in our body will depend on our age, our sex, our size, our level of fitness. So we roughly look at between roughly 8 litres of blood. So if you looked at that in comparison to the total volume, that's quite a small proportion. I'm just making sure I've answered all the questions. What's the difference between perfusion and SpO2? I don't understand the question, so I'm not sure what you're asking there. Okay, can this lead to oedema? So I suppose a short answer to that would be no. Edema is something different. That is something where the body has caused there is a shift of fluid. Edema can cause hypovolemia, so that's a sort of other way around. If you are very edematous in your limbs, for example, you can have a reduction in your circulating volume. So edema could cause a level of hypovolemia, and particularly pulmonary edema, because that doesn't have an obvious visual, i.e. there isn't a part of the body that's swollen, then that can cause you to become hypovolemic. Tissue perfusion, what I talk about tissue perfusion is all of the body. So every single organ in the body, the kidneys, the liver, and the lungs, and the peripheries, and the brain, everywhere. That's what I'm talking about with general tissue perfusion. Oxygen saturation is specifically focused on the lungs and the respiratory system. So what you record when you get a PO2 or SpO2, so oxygen saturations from maybe a probe on the finger, just gives you an indication of what's going on in the lungs and what your respiratory function is like. General tissue perfusion will be referring to the kidneys and everywhere else. So all tissues. In terms of struggling to hear me, I apologise for that. I've got both microphones up to maximum, so I think the problem might be your end. Okay, so I think I've answered all the questions. Any more coming in about hypovolemia or hypovolemic shock? I'm going to answer that question in a minute, because I'm going to come and talk. I'm going to talk about cardiogenic shock, and hopefully that question will be answered. So, just to recap, hypovolemic shock is about a dramatic loss in volume, blood volume here. 15 to 25% of our blood volume has been lost, either through hemorrhage. And what we need to do then is we need to look at what our observations are doing. And as I said then, our blood pressure is going to drop. So our blood pressure is going to go down roughly equally. Our diastolic and our systolic will decrease. Our pulse will go up. We will get a reduction in our blood volume. We will get a reduction in our venous return. We will get a reduction in our stroke volume, our cardiac output. And then all of our tissue perfusion will be reduced. So not just, as was stated, our oxygenation and our respiratory function, but equally all of our other organs, their perfusion will be reduced. So for example, if we were talking specifically about the kidneys, we might get a reduction in our urine output. So it's not just one thing that's happening, it's a knock-on effect on all of the body, and equally the signs and symptoms that we will look for are specific to hypovolemic shock. So this is hypovolemic shock, which is a dramatic loss in volume. Can we become hypervolemic? We don't tend to refer to it as hypovolemic. We can become overloaded with fluid, and that's a completely different thing. And I'm not going to be talking about that today, because it doesn't have the same knock-on effect on the body. So that's hypovolemia. Now I'm going to talk about cardiogenic shock. Now cardiogenic shock is something different, and as it says there, it's sort of suggesting it's got something to do with the heart, and it's about the heart's ability to pump. So in cardiogenic shock, the volume hasn't gone anywhere, but the heart isn't able, for all sorts of different reasons, able to pump our circulating volume around our body. And we can have coronary cardiogenic shock and non-coronary cardiogenic shock, which gets a little bit complicated. So what we're talking about generally is the heart's ability is impaired. We've got a decreased cardiac contractility, so our heart has become impaired in some way, and then we've got the same knock-on effect as before. So we've got a decreased stroke volume and then a decreased cardiac output. So our heart, even though all the fluid that exists in our body is still there, we can't circulate it, we can't push it round. And so the knock-on effect is that we've got a reduction in the tissue, systemic tissue perfusion. So all of the functions are then going to be impaired. The heart, the lungs, the kidneys, the liver, the brain, the gut, and then the peripheries. So coronary cardiogenic shock. That's, when I'm talking about coronary, that means that the problem, the issue is with the heart itself. And an obvious example of that would be when a patient's had an MI. So their electrical impulses in the heart have become flawed for whatever reason, and they've had a myocardial infarction. So part of the heart's muscle has died. Another example of coronary cardiogenic shock might be caused by something like AF, so atrial fibrillation, a cardiac condition that causes the heart's ability to pump is impaired when the atria are fluttering around. So coronary cardiogenic shock is when it's something to do with the heart, either injury or disease or a specific cardiac condition. Non-coronary cardiogenic shock is when the heart's ability to pump is being impaired by external factors, such as a cardiac tamponade, which is where the lining of the heart has been punctured and the heart is literally being squeezed by its own protective layer. Another example of non-coronary cardiogenic shock might be congestive cardiac failure, when the heart itself is functioning but the surrounding tissue isn't. It might be caused by pulmonary edema. So the heart's ability to pump is being impaired by the respiratory system not working. So when we talk about non-coronary cardiogenic shock, we're talking about the problem not being the heart muscle itself, but being associated with it. But the presentation and the management of cardiogenic shock and coronary cardiogenic shock are obviously going to be different depending on the cause. So if the problem is with the heart itself, we need to address that issue. And if the problem is outside the heart, we need to address that issue. So if it's about pulmonary edema, we need to remove the fluid that's in the pulmonary system. And that might be physically or with medication. Equally, if the problem is with the heart itself, then we will need to address the problem that's in the heart. So if it's AF, then we will need to possibly give medication to stabilize the electrical impulses in the heart. How would you identify what type of shock the patient is experiencing is a question that's come in. It's with the patient's presentation. So if the patient in front of you has no visible blood loss, but their blood pressure is going down and their pulse is going up, we'll need to investigate further what's going on. So we'll need to take a full patient assessment and a full patient history to see if there's something else occurring. One of the telltale signs with cardiogenic shock, for example, is although the blood pressure goes down, the rate in which the two measurements go down tend to be different. So whereas the blood pressure in hypovolemic shock goes down equally, in cardiogenic shock the measurement is slightly different. So the systolic blood pressure, which is the top measurement and it refers to cardiac output, goes down but not as quickly. The diastolic blood pressure, for example, on the other hand, goes down dramatically. So there is goes down even less. So there is a narrowing of the blood pressure. So the diastolic and the systolic measurement become closer together. They're going down, but they're becoming closer together. And that might indicate to you that there is a problem with the heart. Equally, if you take the patient's pulse and the pulse is not regular, they might be tachycardic, but it isn't regular, then again, you might look to see if there is something wrong with the heart itself. And we can do easy, simple measurements to see whether that's the case, such as an ECG or actually just putting them on a cardiac monitor. And then we might be able to see exactly what's happening with the heartbeat. So cardiogenic shock. Any questions on that? As the patient goes into cardiogenic shock, yes, the respiratory rate will increase because the patient is trying to oxygenate as much blood as possible as it's going around the pulmonary system. So yes, the respiratory rate will increase. Yes, the presentation of the blood pressure is the same in both cardiogenic shock and non-coronary and coronary cardiogenic shock. It's not non-cardiogenic shock, it's coronary or non-coronary cardiogenic shock. The blood pressure measurement will get closer together, and it will get closer together because although there is going to be a reduction, there's not going to be a dramatic shift in the blood pressure as there was in hypovolemic shock. So peripheral resistance and cardiac output are going to be less dramatically changed than they were in hypovolemic shock. So a narrowing of the blood pressure might indicate to you that there is something going wrong with the heart itself. Somebody's asked what a fluid challenge is. That's a technique that we use to see, for example, if the kidneys are functioning appropriately. And it might be something that we'd do if the patient was either overloaded, i.e. they're suffering from some sort of pulmonary edema or something, and we want to see how much fluid is going to be inputted and outputted over a period of time. Yes, when we're talking about heart failure is a bit of a strange term because it's not really something I talk about. What do I mean by heart failure? There's all sorts of different types of heart failure. If it's an electrical issue, then yes, it is going to be coronary cardiogenic shock. If it's a mechanical issue, it could be either. It depends what's causing the heart to fail. If we're talking about congestive cardiac failure, for example, then we're talking about coronary cardiogenic shock. If we're talking about mitral valve failure, we're going to be talking about coronary cardiogenic shock. So I think we need to be a bit more specific about what we mean by the term heart failure. And it's a bit of a generic term. Okay, any other questions? So the key thing to remember with cardiogenic shock is how it's something that's going wrong with the heart itself. So the volume hasn't gone anywhere. It's still in the body. It's just, it's not being pumped around the body in the right way. How do we differentiate between hypovolemic shock and cardiogenic shock? It's going to be in the presentation of the patient. So we're going to have to look at our patient and appropriately assess our patient. One of the key differences is the blood pressure change, but also there's going to be a visual difference. And there's also going to be a difference in their pulse itself. So it's going to be a combination of a lot of observations and assessments that's going to tell us whether it's cardiogenic or hypovolemic shock. With hypovolemic shock, it tends to be quite quick though, if for example, we're dramatically losing volume. Cardiogenic shock could be something that we build up quite slowly over time. One of the questions is, how does this relate to pneumonia? I'm not absolutely sure I understand the question. How does cardiogenic shock relate to pneumonia?